So I'm going to talk about adult asthma. So we're going to move from pediatric asthma to adult asthma. This is a picture of my 4 kids from 2 years ago. They've grown up a little bit since then. JT is now 14, Will's 11, Caitlin's 9, and Allie-Ann is now 3. The reason I threw this picture up here is again about asthma. Sometimes with asthma, you feel really good and you're happy and doing well. Sometimes with asthma, you're not feeling too good and not too happy. And Caitlin here was not too happy that day about getting her picture taken. So all the pictures we did, this was Caitlin. She did not smile. How many of you have kids in the audience? Okay, you can relate. You raise them all the same way, and they turn out very different, right? Okay, you do the same thing, you treat them the same way, but they turn out very different. Well, if you don't know, a lot of you are friends with me on Facebook, and if you don't know, I grew up a big Clemson fan, okay? My dad went to Clemson, grew up a big Clemson fan. So my boys, they love Clemson. But Caitlin, she likes the Gamecocks. I don't know what I did wrong, okay? If any of you can help me, tell me what I did wrong, let me know. But, again, the whole point of this being is that, with asthma, you want to get them to a point when they're doing well, all right? So here's another of the things from the post office. I love going to the dentist because I like how it feels to have someone gently touch my face. And then I don't have insurance. My cable bill's late, but I have this great new pair of sunglasses. Any of that? Any of y'all? All right. So we'll do a case again. This is an 8-year-old white male who presents with shortness of breath and cough. Symptoms are worse at night and in the a.m. Patient has tried immunotherapy in the past but stopped after 8 months because of increased wheezing with allergy shots. What other questions would you like to ask to help with the diagnosis? Pets in the house, great question. Do they sleep in the bed? That's a great question. When I test people and they come up to dogs and cats, that's one of the first questions I ask them. I said, not only do you have a pet, I said, do you sleep with them? And it's amazing the number of people that do sleep with their pets and stuff. Okay? What other questions? Okay, what was the allergy shots to? Good. Does he have reflux? Reflux commonly gets worse at night. So that's another great question. Other questions over this side of the room. Has he had flooding in the room? I like that one. Why does that matter? Maybe they have increased mold growth and they're allergic to mold. So another great question. Anybody else? What else would you want to ask this patient? Does he sleep with the ceiling fan? Why are you asking that? Because of the dust. Okay, so maybe at night, one of the common problems people have at night is dust mite allergy. They say, hey, I do great during the day, but every morning I wake up stuffed up and my asthma acts up at night. Maybe they're allergic to dust mites. It's all hand in the back. What else? Okay, so do you have carpet? Do you have hardwood floors? How old is the house? Anybody else? What other medicines do you take? Good. All right, and I'm going to give you some of that in just a minute. All right, anybody else? Smoking. Do you smoke or not? So again, you assume because you're at an allergy lecture there's going to be asthma. It may not be asthma in the end. So again, you got to keep kind of open mind. Is this really asthma or if there's something else going on? Let's keep going. So this person has daily nasal congestion and postnasal drip. Patient does have burning and itching eyes. Denies any seasonal pattern to symptoms. Symptoms are worse around cats, dog, smoke, dust, grass, and perfumes. Question I have for you. How reliable is it when patients say they have problems around these things? How reliable is that predicting allergic rhinitis? No, it's about 50-50. So that's why we do allergy testing, because I have a lot of people that come in like this and they say they have problems around things, and then I allergy test them and they're not allergic to any of them. Okay? And this person, saying that they're having problems around perfumes, that's more typically non-allergic rhinitis anyway. So we don't have any kind of skin testing where we can check for perfumes. So that's more of an irritant than it is an allergen. So again, benefit of doing either skin test or immunocaps to really figure out if they have allergic rhinitis can be beneficial. Patient has chronic yellow-green productive cough and rhinorrhea. What does that make y'all think about? Say it again. So sinuses, so chronic sinusitis. What else could it be? Some kind of chronic bronchitis. Okay, there's a lot of things that could be, but top two things are probably bronchitis and sinusitis you're going to think about. Patient denies being treated for many sinus infections in the past. Patient also complains of continued burning in chest and belching despite proton pump inhibitor. Has positive throat clearing. They have a BMI of 34, so they're real skinny, right? Wrong? Okay. Patient has really no past medical history, no allergies. And again, we're going to talk about in adults now. How do you make the diagnosis of asthma in adults? What are you wanting in this patient now to help figure out what's going on? So spirometry. So definitely going to get spirometry. And again, looking for the same thing as we did in the kids. We're looking for obstructive, reversible airway disease. Again, 12% improvement and 200 cc's is what we're looking for. What else are you going to want? So CT. Do you want a sinus CT or sinus X-ray? Yeah, so he says sinus CT is what everybody gets. So he's right. Sinus CTs give a lot more detail. The sinus X-rays, you can see a lot more of the anatomy. What we, as allergists, see chronic sinusitis as is an anatomical problem. What we're looking for when we get a sinus CT is to see if there's any obstruction of the osteomeatal complex. We want to see if it's a plumbing problem, to see if it's blocked up, and see if they do need a referral to the ENT. Because not always with chronic sinusitis do they need a referral to the ENT. If they don't have obstruction of their sinuses, you probably can treat it with antibiotics, nasal steroids, prednisone. A lot of times those patients clear up and don't need surgery. The ones that need surgery typically are the ones that are blocked up, so you can open up the plumbing so they can drain better. So again, that's where the sinus CAT scan can help. What else would you do to help with the diagnosis of asthma? So you said spirometry. Any other test? So PFT. Okay. What else? Nitric oxide. So nitric oxide may help too in figuring out if this is asthma or some kind of other inflammatory disorder going on. So let's keep going. So in adults, the diagnosis of asthma is really based on history. So you get a good history, you can make the diagnosis of asthma just as a historical diagnosis. Exam and PFTs help increase the likelihood that it's asthma. So if you see reversibility, if you see obstruction, much more likely that it is asthma. So again, you don't have to have PFTs to make it, but it's going to help you in figuring out what's going on. Other things that make it more likely, cough that's worse at night or in the morning, or with laughing or talking or with exercise. So if they have a cough that does that, more likely. Wheezing. Again, wheezing's a high-pitched whistling sound when breathing out. And what I'd say in the majority of my asthma patients, I rarely hear them wheeze. And so that's one thing that this says is that you have a positive predictive value of 42%. So if they are wheezing, it's only about 42% likelihood that it is asthma. If you don't hear wheezing, then you know that 83%. So again, just because they don't wheeze doesn't mean it's not asthma. So keep that in mind. Asthma can just be one of the 4 typical symptoms. It can just be coughing. Coughing in asthma means just that. They're only coughing. They're not wheezing. They're not short of breath. They're not having chest tightness. So again, the more of the symptoms you have, the more likely. But again, just because they don't have it doesn't mean that they don't have asthma. And again, remember, asthma, you're just seeing a person at a point in time. So they could be doing terrible an hour after they leave you or an hour before they get there, but when you see them and you get that spirometry and it's normal and they're not having symptoms, doesn't necessarily mean they don't have asthma either. So again, remember, it's just a point in time that you're seeing them. You may only hear wheezing if you ask them to blow out really hard. So one thing I do on an exam is I listen to normal chest sounds, and then I ask them to take a deep breath out, and sometimes the wheezing comes out when you do that. Other symptoms, shortness of breath, chest tightness, and they have several studies showing that physicians aren't very good at predicting lung function based on symptoms. So I see asthmatics who I think are doing terrible, and I get spirometry and it's normal, and I see others that I think are doing great. I get spirometry and the FEV1 is 60%. So we're not always great about doing that. So again, it goes back to One thing I want you to really think about doing, if you're not doing now, is that your asthmatic should have probably spirometry at least once a year. So I really encourage you to do that because you'll find patients that can be treated better if you're getting spirometry. Other things you can see, especially in kids, are retractions, hyperexpansion of the thorax, especially in COPD, use of accessory muscles, again, that's more in kids, nasal symptoms, and then atopic derm. So we've already talked a little bit about like this, so we'll keep going. Here's another one. What happens at church camp stays at church camp. And this is probably my favorite. My landlord kept my $200 damage deposit. I kept his $2,000 chandelier. All right, so here's some of the tests that we ended up getting with this patient. We got spirometry. We did a pre and a post. So we did the spirometry, gave them albuterol. 15 minutes later, we checked their spirometry. We got exhaled nitric oxide on this patient. We went ahead and did skin testing to figure out if they're allergic or not, and then we ended up getting a CAT scan. So here's your test for the day. A normal chest x-ray excludes asthma. How many people want to say true? No. Good. How about how many people want to say false? Great. So the big thing I want to point out with this, probably 90% of my asthmatics I never get a chest x-ray on. So the only time I get a chest x-ray is if I'm concerned about some other problem going on, if I'm worried about pneumonia or something else that would make me get a chest x-ray. So majority of my asthmatics, I don't get a chest x-ray unless something else is going on. Normal pulmonary function tests exclude asthma. How many of y'all say true? How many say false? False again. Asthma is a point in time. So if they're doing well, their spirometry may be great. If they're doing bad, their spirometry is going to be bad. And again, the interesting thing I'm learning about asthma, especially since we started doing nitric oxide, I have a lot of patients that have normal spirometry. I've never seen an abnormal FEV1, but I get their nitric oxide, and their nitric oxide is 100. So again, I think with asthma, you have different kind of phenotypes. You have some people that have more bronchoconstriction and not as much inflammation. You have these other people that have lots of inflammation, but you're not seeing the bronchoconstriction on spirometry. So again, all these different tests help us figure out how to treat and what's going on. And then finally, a person with a chronic cough with no shortness of breath, wheezing, or chest tightness does not have asthma. How many people say true? Again, false. And that goes back to Dr. Jane's talk, is that you can have cough fearing asthma. You don't have to have wheezing or shortness of breath to diagnose it. So just a little bit of review. So with spirometry, the main things we look at is the FEV1, which stands for forced expiratory volume in 1 second. And the reason we like using that rather than a peak flow is it's got less variability, it's more consistent. So if we had to choose between the two tests, we would typically take spirometry. Peak flows have the value, they're easier to do at home. FVC is the forced vital capacity, and it's the maximum volume of air forcibly exhaled from the point of maximal inspiration. We use that too. Again, we talked about it earlier. We recommend spirometry in kids, usually typically around age 5 to 6. And again, it depends on how they do it. Some 4-year-olds can do it. Some 8-year-olds can't do it. So again, we work with them and try to get them to a point where they can do it consistently. And this is one of the most important points is, again, you have kids and adults who tell you they're doing great. They tell you they're not using their albuterol. They tell you they're doing really well. But then you get their spirometry, and it doesn't agree with what they're telling you with. So again, I want to encourage you, if you don't get spirometry, it can really help sometime in reclassifying your asthma. Same thing with NIOX. I have patients come in, tell me they're taking their medicines, get their NIOX, and it's over 100. For both spirometry and NIOX, if they show abnormal levels, it increases the risk for exacerbations, increases the risk of having problems. So it can be an early sign of people who are at risk for having problems. We've talked about reversibility already, so I won't go over that again. I do want to emphasize that people with a lot of reversibility may be at greatest risk for irreversible lung disease. So again, getting that better is going to help. This just shows you what a normal spirometry curve looks like. And again, what we're looking for is the picture up in the top left-hand corner is we're looking for airflow obstruction. So it's usually this scooped out curve that we're seeing on this. The bottom two pictures show that some people can have extra thoracic, the FEF 2575. This is a marker for small airway disease. So again, this person's only 20% prediction. So not only do they have large airway disease based on the FEV1. This person has evidence of small airway disease, which goes along with asthma. We've already spent a lot of time talking about exhaled nitric oxide. And the thing I want you to know about exhaled nitric oxide, that in adults, if it's over 35, is a marker of inflammation. And the FE note indicates that they're more likely to respond to inhaled steroids. So it helps us kind of pick what medicine to start them on a lot of times. They're also more likely to respond to a lot of the monoclonals we use. They're also a marker of compliance. And again, if we get their levels down, they help decrease exacerbations. I'm not going to spend a lot of time on this slide, but this goes back to the National Heart, Lung, Blood Institute guidelines, and that you have to classify your patients again based on their symptoms and awakenings and albuterol use. And one thing to note with adults, their FEV1, the FVC ratio decreases as they get older. So if you're looking at a 60-year-old, 70% is normal. So just keep that in mind when you're looking at this ratio to determine if it's normal or not. I put this one in there for Dr. Hill and Dr. Sine. This is somebody that saw them in their office that they have to deal with. I'd rather get skin cancer than be pale. All right? We've already talked about this. This is very similar to the kids. I'm not going to spend a lot of time on this slide, but this is how we classify asthma again. And again, this is very similar to the kids for control. If you're having symptoms more than twice a week or twice a month at night, then you're not well controlled. Another one, I know I make you miserable, and that's why I keep in touch. All right. So this is the last part I'm going to wrap up. This comes from the ATS with severe asthma. So how do we decide if somebody has really bad asthma that we really need to watch? ATS criteria say that if you have one of these major criteria, continuous high-dose inhaled steroids or oral steroids for greater than 50% of the previous year moves you into very severe asthma criteria. And then the minor criteria are requirement for an additional daily treatment with a controller medication, so any controller, asthma symptoms requiring short-acting beta-agonist use on a daily or near daily basis, airway obstruction FEV1 less than 80%, one or more urgent care visits per year, 3 or more oral steroid bursts per year, prompt deterioration with 25% reduction in oral or inhaled steroid use. So when you drop them down, they get really bad, okay? And then if they've had a near-fatal asthma event in the past. So the reason this is important, these are questions you probably should incorporate in, especially if you're severe. If they have any of these criteria, they're at more risk for problems, probably need to be on stronger medicines, more risk for hospitalizations, oral steroid use. And this kind of shows what it means to be severe. 12% of these patients had an ICU stay in the last year. 70% reported worsening with decrease in inhaled steroid. Most severe asthmatics met 5 to 6 of the minor criteria. And a lot of these, when you try to do reversibility, you don't see the reversibility. They have now irreversible lung disease, so they look more like your COPD patients. Some of these patients, to evaluate reversibility, instead of giving them 2 puffs, you need to give them 8 puffs to be able to see reversibility. A lot of these have increased history of pneumonia. And then, again, a lot of, in women especially, they may have increased exacerbations during menses. These are 2 different studies in severe asthma, and one of the studies said that older people were at more risk for severe asthma. Another study said that females at a 4-to-1 ratio was at increased risk. One of the studies showed an increased weight in females. And one of the interesting things is in adults, it kind of switches from kids. These people a lot of times have less allergies than the kids do. So not to say that people with allergy don't have severe asthma, but a lot of these people don't have allergies when you do skin testing on them. Aspirin sensitivity, there is a disease called aspirin-induced respiratory disease, where people, when you give them aspirin or Motrin, their asthma worsens. They also have nasal polyps. And again, you see this more in the severe asthma population. Sinusitis is a marker of severe asthma, and then GERD can be a marker of severe asthma. And I just want to point out here of the ones that are most important, chronic sinusitis. So if you got a severe asthmatic and you haven't looked at their sinuses, you probably need to. That's what this slide's telling you. Same thing, rhinovirus is positive in these, and then these patients have higher levels of eosinophils and nitric oxide. I like doing this to my mom. Anybody do this to their moms? Okay, so what would you recommend for treatment? I'm just going to try to keep it going, but so here's your step therapy. This patient has severe asthma, so we're probably getting up to step 4, 5, or 6. So they're probably going to be on some combo treatment. Once you max that combo treatment out, you think of something like your Singulair to add on. If that's still not working, we're looking at maybe adding on Spiriva. And then at that point, we're starting to look at monoclonals. And the one thing I really wanted to focus on is that there's 2 new monoclonal antibodies that have come on the market in the last year for asthma that I wanted to discuss. This comes from the National Heart, Lung, Blood Institute, that if you have asthmatics that are step 4 or higher, they should see some specialists, so an allergist or pulmonologist, and they recommend considering consultation at step 3. So this patient, we put on Advair 230, 21, 2 puffs twice a day, still symptomatic, came back 2 weeks later. We added Singulair, still not better. We added Spiriva Respimat. One thing about Spiriva, the only one that's indicated for asthma is the Respimat at the 1.25 dose. The 2.5 dose is indicated for COPD, and your old Spiriva is indicated for COPD. So the only one that really has an asthma indication is the lower dose. Can you use the higher dose in asthma? Sure, it just hasn't been studied in asthma yet. So here are our 3 biologics. Xolair's been on the market for about 12 years, and the other 2 are new, and I'm going to spend more time talking about them. Xolair, again, omalizumab is a monoclonal against IgE. It's given subcutaneously either every 2 weeks or every 4 weeks. We decide that based on their IgE level and their weight. It's indicated for ages 6 and above. In adults, they have to have an IgE level between 30 to 700. In kids 6 to 12, it goes up a little bit. It goes up, I think, to 1,200 in the kids. And they have to be positive to a perennial allergen. So they have to be positive to dust mite, cat, dog, cockroach, not a seasonal allergen. And the studies show that if you add this on to therapy, that you have the likelihood it's going to decrease exacerbations. Nucala, mepolizumab, is also sub-Q. It's every 4 weeks, and it targets IL-5. IL-5 is important in recruiting eosinophils to the lung, and so it helps decrease the amount of eosinophils in the lung. To qualify for it, you have to have a diff showing eosinophil levels greater than 150, and it's indicated for 12 and above, and it shows in the studies that it helps decrease asthma exacerbation, also shows longer time to first exacerbation, and also if you have somebody that's on chronic oral steroids, you can help get them off that. And our final one, Singulair Resoluzumab, it's our newest one. It's IV. It's every 4 weeks. It also targets IL-5. The main difference between that and Nucala is IV, and you need a higher eosinophil count to qualify for this one. So your eosinophil count has to be greater than 400. It has a higher age indication, 18 and above, and it's the only one in the studies that showed an improvement in the FEV1. So that's one thing that's a little bit different for this one than the other one. So if you got somebody with a really low FEV1, this may be a good choice to think about. Other options, allergy shots are an option in the National Heart, Lung, Blood Institute. Guidelines recommend thinking about them from step 2 to step 4. The big thing with allergy shots is their asthma has to be pretty well controlled to put them on it, because we're giving them something they're allergic to, and if they have an allergic reaction and their asthma's already acting up, that can be a bad combination. So we a lot of times have to get them controlled before we really start their allergy shots. Studies show that allergy shots help decrease medication use and symptoms. And then the final therapy is bronchial thermoplasty. I don't know if you notice out there, but the rep with the bronchial thermoplasty is out there. It's a neat procedure where they have to go see the pulmonologist. The pulmonologist goes in and does bronchoscopy on them, and what they do is they use the thermal energy and they pretty much burn certain areas of the lung. And what they found is that by doing that, it reduces the excess airway smooth muscle, and they have shown in studies to have reduction in asthma attacks, ER visits, and hospitalizations maintained up to 5 years. So again, this is indicated for your real severe asthmatics. But it's, it is a good option when nothing else is working. All right, so I think my freckles are sexy and yours are too. And the final one, girls say goodbye to tiresome dirty dishes with this handy little gadget. I hate doing dishes so much that sometimes I just throw them in the garbage and buy new ones. All right, so Dr. Roop's going to be coming up here. Any questions before he gets started?